I really wanted to thank the organizers for inviting me. I've really been listening very closely and I've learned a lot, and I hope that what I've learned is reflected in what I tell you today. And I especially wanted to thank Kathy and Shabir. I'm really glad to follow them because they've brought up a lot of issues that I think I'll allude to as we talk about RSV vaccines. So, for those of you who might not be familiar with respiratory syncytial virus, or RSV, it is the leading cause of hospitalization in infants and in many high income countries. More than 2 million medical visits annually in the US are attributable to RSV infection. There, as I'm sure many of you know, Harish Nair and colleagues published an estimate of the burden of RSV globally that's going to be updated very soon, but the 2005 estimates were 33 million cases of acute lower respiratory illness, 3.4 million cases of severe ALRI, and 160,000 global deaths. So in contrast to Group B strep, and I'm very happy to follow the Group B strep discussion, the burden of RSV is largely post-neonatal. So these happen to be data from Argentina, but they could be data from almost anywhere. And what you can see is that there's relative sparing in that first month of life. This happens to be hospitalization, but you could look at other measures of severity. And that becomes important when we're thinking about issues related to mortality, and we'll talk more about that in a moment. But the burden is largely in infancy, but after the first month of life. So there is a huge, the RSV vaccine development pipeline has exploded in the last few years. And I wanted to tell you a few things about this. The first is, as I always do, to say that this RSV vaccine snapshot is very nicely provided by PATH and updated about every 6 months. You can see the URL, and it's really a terrific service to the community. The second thing is I was actually talking about this with a couple of colleagues at lunch, and I wanted to actually reflect on this turn of events, because I've been in RSV vaccines for a long time, and 10 years ago there were about 3 candidates. And what is it that has gotten us here? Why are we here? And it's interesting because it's not recognition of the burden of disease, because to be perfectly honest, although I think there's tremendous effort to make global vaccines for simultaneous implementation in high, low, and middle income countries, the drivers for development are really the burden in high income countries. And the burden in high income countries has been appreciated for decades. We haven't, certainly in young populations, we haven't learned huge new things about that. It's also not disruptive technology. We may have new technology in the future that's going to let us develop novel RSV vaccines, and I think that will be interesting. But the technologies that are being used, which are for the most part development of subunit vaccines and live attenuated vaccines and some live vectored vaccines, really have been around for decades. These are not novel technologies. I think, in my own view, I think it's really a couple of things. I think it is, as I put it, the next mountain to climb in pneumonia. So as we were really able to control bacterial pneumonia, as we developed excellent vaccines for Hib and pneumococcus, it was the next target with respect to childhood pneumonia. And I also think very strongly that it was the acceptance of maternal immunization as a way forward. There were people who, Paul Gleason talked about maternal immunization for RSV decades ago, but there was no traction for that at that time. So it's really, I think it's follow-on to the influenza pandemic and the appreciation of maternal immunization as a platform. So I wanted to say a couple of other things about these various candidates, and you can see that I've annotated this slide a bit There are vaccines that are being developed for maternal use. There are vaccines being developed for infant use. The likelihood, maternal vaccines will probably precede, availability of maternal vaccines will probably precede availability of typical infant vaccines, and we'll talk about the exceptional vaccine-like candidate in a second. But I think there's a great appreciation that if we're talking about overall reduction in burden of disease, that we probably want some sort of a passive active strategy, just as we have for pertussis and we have for influenza. We probably want that for RSV as well. The one exception, I said that the maternal strategy is passive. There is also an extended half-life monoclonal antibody being developed by MedImmune that is predicted to have vaccine-like pricing that could be given either at birth or could be given seasonally. Its development path accommodates both of those possibilities, and that would be a passive strategy, but given to the infant rather than given to the mother. So I thought it would really be good to sort of to talk, because I think a lot about RSV, but I'm sure that not everybody here does. And I wanted to talk a little bit about the kinds of illness, acute illness, that we're trying to prevent. I'm going to talk about long-term effects and indirect effects, but just focusing for a moment on acute RSV illness. There's a spectrum of illness. I think the rank order in this pyramid is correct, but the absolute proportion that's in each of these blocks is not necessarily visually represented correctly. And some of this is unknowable. So upper respiratory tract and otitis media. We know that all children are infected with RSV by about 2 years of age. So this is probably ubiquitous. Otitis media may not be ubiquitous. RSV, upper respiratory tract illness, probably is. We don't measure it, and I would argue, nor do we particularly need to measure it. I think we know much more about acute lower respiratory tract illness, non-severe and severe, and I will just tell you that RSV causes a couple of different overlapping lower respiratory tract syndromes. It causes bronchiolitis, which is an infant wheezing illness, which probably is virally mediated and perhaps only virally mediated. And it also causes pneumonia, and that may be, as we'll talk about, a combination of some viral and bacterial interactions. And I wanted to say something about death. And again, I think thank you, Shabir, for the comments that you made about death in GBS and death in RSV. I completely agree with you. I think the burden, when we think about the burden of RSV, the burden is not a death burden in particular. It certainly does cause death, but for example, the recent PERCH study showed that the case fatality rate for RSV was 2.8%. Because RSV was so very frequent, the leading pneumonia diagnosis in that population of hospitalized infants, it was 7.2% of all of the severe and very severe deaths. But the other thing I just wanted to superimpose on the spectrum of disease and to have us think about as we think about the potential benefits of vaccination is sort of a likelihood of success. So not only do we not quantify RSV, upper respiratory tract illness, for reasons that perhaps we can talk about during the discussion session if there's interest, is that I think that the more severe we go in the disease, the more likely these vaccines are to be effective. So I think they're going to be very effective against death. I think they're going to be very effective against severe ALRI. I think they will also be highly effective against any ALRI. I think when we get into those milder illnesses, I think our probability of success is less in any case. So certainly, I think that that's been recognized by everyone who's, as you can imagine, with this incredibly robust vaccine pipeline, everyone is trying to develop case definitions for what are we as we do these efficacy trials. And there is one RSV maternal vaccine currently being tested in phase 3 trials. What are we after? What is the case definition? And there are various iterations of this, but essentially these are an RSV positive by PCR, lower respiratory tract illness with some measure of severity. And as various companies have worked on RSV vaccine development, they have tweaked these and modified these, and their pulse oximetry measurements vary, but essentially they're all flavors of this, reflecting that this is what we're after in terms of the acute effect. So in terms of thinking about this, if we think about RSV and what kind of impact could the vaccine have, remember that I told you that this is not primarily a neonatal pathogen. So if we look at the curve of the under 5 mortality rate, you can see that in any instance, RSV did not contribute hugely to mortality, and mortality is declining. So when we think about RSV, I think we really, really need to focus on the morbidity burden and not on the mortality burden. So this is really just to reiterate that when we're focusing on RSV, I think our attention is properly focused on acute lower respiratory illness and severe ARI. Where I think we're stumbling and where I think we could use some rethinking and some broader thinking is how we conceive of that and how we broaden our definitions a bit. And so I want to spend just the next few minutes talking about acute indirect effects of RSV vaccination, potential acute indirect effects, and potential long-term effects, both related to initial ALRI. So in particular, when I talk about acute indirect effects, I really want to think a little bit about viral bacterial interactions. And I'm going to spend a couple of minutes talking specifically about a pathogen pair, which is RSV and pneumococcus. And then I'm going to encourage us to think more broadly about RSV and the respiratory microbiome. So it's really terrible to present a landmark study when the first author is right here in the room, but I will really do my best, and Shabir, you'll feel free to correct me when I misspeak. But this was really a very important study done by Shabir and his colleagues that actually leveraged the PCV9 efficacy study to look at other effects. And what Shabir showed is that particularly in the case of RSV pneumonia, though interestingly not RSV bronchiolitis, but RSV pneumonia, that in fact there was efficacy of a pneumococcal vaccine against children hospitalized with a diagnosis of RSV pneumonia. Now, how do we understand this? And again, this is a place where during the discussion, Shabir could certainly correct me. I think when this was originally published, some people initially said, oh, does that mean that pneumococcal infection causes RSV disease? And my understanding of the interpretation is not that, but rather that RSV infection complicated by pneumococcal infection leads to more severe disease and hospitalization, which was the measured endpoint. So that there may be pneumococcal infections that we don't appreciate that lead to that we diagnose as RSV because we can easily do that with an NP swab, but that in fact complicate those infections. And I actually pulled my mice slide out of this slide deck, but there certainly are mice data that suggest that that RSV infection increases pneumococcal binding to epithelial cells, so that suggests that there is an interaction. This is a study by David Weinberger and his colleagues that actually looked at correlations between RSV hospitalizations and pneumococcal pneumonia hospitalizations, controlling for seasonality and controlling for influenza infection, which could be a very important confounder. As you can see, they showed a nice correlation, and in this particular study, they actually showed a lag, so that the average epidemic timing of pneumococcal pneumonia lagged behind RSV by about 1.5 weeks. So I think that some of these, as I said, sort of pathogen by pathogen analyses are important, but I think we're appreciating more and more that these infections, these are not sterile site infections. These infections with RSV are occurring in the context of a microbiome. And I think that our understanding of the nasal microbiome has lagged behind our understanding of the gut microbiome. But I think increasingly we're understanding how important this is. This is a study that just was published last month that looked at, that divided, it looked at children with severe RSV and non-severe RSV, and looked at various classes, were able to classify into various groups of pathogens in the microbiome. And what this particular study showed is that for Haemophilus and Streptococcus, you can see the inpatients are in white, that there was a positive association with severe RSV disease. Conversely, a negative association with Corynebacterium, Moraxella, and Staph aureus. And what was particularly interesting to me about this study is they also, in addition to looking at the bacteria that were in the nose, they also looked at inflammatory mediators. And what they found is that the RSV in and of itself produced induced interferon signaling, as you might expect for a virus, but that particularly infants who had Haemophilus and strep had a distinct inflammatory response that was related to neutrophil recruitment, TLR signaling. So suggesting that, in fact, we don't necessarily have to see a bacterial pneumonia to see the inflammatory after effects of this virus-bacterial interaction. So there was Jim Gurn wrote an editorial in this same journal where he actually postulated what the pathway might be. And what he suggested is that there's a pre-existing microbiome, RSV infection, that then somehow this virus interaction with the microbiome alters the microbiome. And either it's dominated by pathogens or it's not. If it's dominated by pathogens, there's inflammation and airway obstruction. If it's not dominated, then you have asymptomatic infection or mild illness. So I think this is a really interesting way to think about this. He was commenting on the article that I just showed you, and I should just comment that that was a snapshot. That was a point in time. And so this part of this graph is a bit of speculation. In other words, you don't know what is the chicken and the egg. Did the RSV infection change the microbiome, or was there an abnormal pathogenic microbiome that RSV just happened to land in? Not really clear from that paper. However, This is another study that was done of the respiratory microbiome in young children and looking at respiratory infections, not particularly looking at RSV. And the advantage of this study was actually it was a longitudinal study. And I think there are a couple of things that are interesting about it. One is that this same predominance of Haemophilus and Streptococcus is seen in children with acute respiratory illness as compared with healthy children longitudinally. But importantly, and I think it shows the value of these longitudinal samples, there are some trends that appear to be age-related. So for example, staph decreases with increasing age. Many more of these newborns or young infants were colonized with staph as compared with older infants. So that's what I wanted to say really about RSV and bacteria. I now want to talk about RSV and long-term effects on lung health. And I wanted to focus a little bit. There are many, many, many ways to think about wheezing and to categorize wheezing. And there's really an explosion in our understanding of asthma from a genotype perspective, from a phenotype perspective. But I actually wanted to go back to a really old, what's now an old and classic description by Renato Stein and Fernando Martinez, which is an epidemiologic description, which describes children who wheeze in early life and beyond. And these were longitudinal studies granted in the US, and I think that's an important caveat that we don't absolutely know how these apply to other settings, but of thousands of children followed through the first several years of life. And what they described is that there were these three phenotypes. There were children who wheezed early in life, usually because of a viral infection, and that they had wheezing in early life, but really it disappeared by about age 5, and we call those transient early wheezers. There were then children who started a little bit later, might have started at 2 or 3 years of age, and they might have had wheezing into early school age, but eventually it sort of also tailed off. Those were children who weren't particularly allergic. They were called non-atopic wheezers. And then there were the allergic wheezers, and those children tended to start much later. That's that third graph. And persisted into adulthood. Why do I bring this up? I bring this up, and again, it's something we could discuss, because it's most likely that RSV, that prevention of RSV LRI, I think is most likely to have an effect here, that you can sort of rank order the likelihood of effect. And transient early wheeze is a condition that is underquantified and undervalued. So I think Brad's point yesterday about we pediatricians don't value adult disease enough is well taken. But I can tell you that when I talk to pediatric pulmonologists about transient early wheeze, what they say is whenever we go to a pulmonary meeting, to a lung health meeting, we think this disease is important. We don't really have adequate metrics for this disease, and we'll talk about some things that could be applied, but what they say is children aren't as healthy. They are not as active. They don't do as well. But when we talk to our adult pulmonology colleagues, they say, yeah, but they're not wheezing at 8 years of age. Yeah, but they don't have, chronic obstructive pulmonary disease. It all goes away, sort of, what do we care? So I would argue that we should care and we should have better metrics. So I wanted to talk a little bit about the evidence for links between early RSV disease and long-term lung health. There are ecologic and there are intervention-based data. And what I think I will do in the interest of being quick is to skip through, you'll have this slide set. I'm going to skip through the ecologic data. I'm going to say something about intervention studies. There are only There are actually 3. There are 2 listed here, both with RSV monoclonal antibodies. I will just say quickly that they seem to show different things, but there are tremendous complexities in these data. And I think that they highlight the need to do these intervention studies and to do long-term assessments. And again, we can talk more about that. I did want to highlight, so we can measure, in terms of long-term studies, we can measure wheezing. We can also measure, we now have the ability to measure lung function. And we have the ability, these are data from Heather Czar's group. And I think what's really important is both that we can measure lung function really early in life if we want to capture some of those transient early wheezers. So we can measure it at a year of age. And we can do it with low technology, easy to use technology, so we can go out into the field and do it. What's interesting about this study, what Dr. Gray and her colleagues showed is that the odds ratio of increased respiratory rate was in children who had, this is not RSV specific now, this is LRTI, but if you looked at 1-year-olds who had even a single LRTI, they had an increased odds ratio of increased respiratory rate at a year of age. And then if they had severe LRTI or more than 1 episode, that's odds ratio increased. As you had a greater burden of ALRI, there was also, by these lung function measurements, diminished tidal volumes and an increased lung clearance index, which is an indication of small airway disease. And importantly, and just very quickly, these abnormalities were observed. There was a belief that you started with abnormal lungs and then you had abnormal, that this was happening to children who were born with abnormal lungs. They did these assessments at 6 weeks in a year, and these abnormalities were observed in children who had normal lungs at 6 weeks. So you don't necessarily have to be born with abnormalities. So last slide. Taking all of this into context, so there are a lot of really interesting mechanistic sorts of studies that can be done, but to think more broadly and think about how can we properly value RSV vaccines. One is, I think that we should, in our efficacy studies, include assessments of all-cause pneumonia and acute lower respiratory, all-cause ALRI. But this will allow us to look both at pathogen-pathogen interactions as we've described, but also, and again, we can talk during the discussion section, I haven't said anything about pathogen replacement, but if we look at all-cause disease, that would allow us to assess that as well. We really do need to establish cohorts during these efficacy trials that could be followed for long-term wheezing and lung function outcomes, and I would argue that we should be measuring both. And then the last thing I wanted to leave you with is sort of embrace the heterogeneity. I've had people say, what's a typical population for impact of RSV vaccination on long-term wheezing? And what I would leave you with is I have a colleague in a middle-income country who has said to me, I have 2 populations that I follow, one in a rural community and one 2 hours away in not a city, in a town. And in that town, all these kids wheeze. And actually, when I look at, their noses, a lot of them have nasal IgE. And out in the rural community, there are many few wheezers. And these people live 2 hours apart. Is this helminths? Is this endotoxin? Is this air quality? I mean, you could come up with a lot of explanations, but I think that it is by definition going to be heterogeneous, and we should certainly acknowledge that. We should gather the data to assess how heterogeneous it is, and we should build it into our models. And I will stop there. Thanks.